Inhalers are the mainstay of asthma and COPD treatment, but up to 9 out of 10 patients make critical errors when using them. Respiratory diseases, including asthma and COPD, account for 1/3 of hospital admissions in England, and the UK has some of the highest respiratory death rates in Europe. It is estimated that 2 out of 3 deaths from asthma are preventable. In the UK, 70% of inhalers are metered dose inhalers, containing propellants that are potent greenhouse gases. These inhalers contribute around 3% of the entire carbon footprint of the NHS, which is the single biggest contribution from any medicine. We have a golden opportunity to tackle these challenges simultaneously in order to improve respiratory patients' outcomes and reduce carbon emissions. We can approach this using a series of simple actions: ensuring early and accurate diagnosis, optimising disease control following local or national guidelines, carefully selecting the device using a shared decision-making process, and asking patients to return all used or unwanted inhalers to pharmacies for appropriate disposal. When a diagnosis of asthma or COPD is suspected, this should be followed up with tests for confirmation. Spirometry is vital to confirm a diagnosis of COPD. For asthma, this should include spirometry and one other objective test, such as fractional exhaled nitric oxide. Treatment should be reviewed accordingly, and it is crucial to avoid leaving patients on inhaled therapy without a confirmed diagnosis. The aim in optimising disease control is to minimise symptoms and reduce exacerbations. This improves quality of life for patients, reduces mortality, and is the most effective way to lower the overall carbon footprint, both from healthcare usage and medications. Personalised, patient-centered care is crucial, including patient education, a personalised asthma action plan, and regular review of treatment, adherence, and inhaler technique. The majority of the inhalers used in asthma are short-acting beta agonists, which only temporarily relieve the symptoms of poorly controlled asthma and do not treat the underlying inflammation. Their overuse is a sign of a problem and associated with increased mortality, so it is crucial to identify and review these patients. Inhaled corticosteroids do treat the underlying airways inflammation in asthma. However, these are still underprescribed and underused, resulting in suboptimal disease control. Ultimately, we need to stop over-administering medication associated with poor outcomes, while promoting the correct use of medication which reduces symptoms and exacerbations. When choosing an inhaler, it is important that this is a shared decision taken with the patient to achieve disease control with a device the patient can and will use. Where there are several clinically appropriate options, a low carbon footprint, propellant-free inhaler should be offered first. If a patient is already receiving a high carbon footprint metered dose inhaler, an individualised assessment should be carried out regarding changing. For some patients, such as children under 12, propellant-free inhalers may not be appropriate. Where a metered dose inhaler is the most appropriate option, each device's carbon footprint should be incorporated into any shared decision making. Quick reference guides are available to assist with this. Inhalers must never be disposed of in household waste, as they end up in landfill. This allows destructive greenhouse gases to be released into the atmosphere. Instead, encourage patients to return them to the pharmacy for incineration or recycling. Following the principles of early and accurate diagnosis, optimising disease control, selecting an appropriate device for each patient, and encouraging appropriate disposal, we can improve the quality of respiratory care for patients, whilst also minimising the harm we are causing to future generations. For more information, you may find these resources useful.